Hi, Stefan Harvard here, Iron Direct Primary Care. And in today's video, you're going to hear a lecture that I attended earlier this week with Dr. Mark Gordon. And he is a specialist who's been studying traumatic brain injury and neurosteroids. This particular part of this video has been cut where he gets into the neurosteroids, pregnenolone and DHEA, testosterone, estrogen, and progesterone, so that you can learn a little bit about these and how critical they are to one, the traumatic brain injury patient, and two, the aging brain, because the TBI and the aging brain both cause neuroinflammation. And by hormone replacement therapy, as we will learn here, you can prevent and potentially reverse a lot of these cognitive problems and cognitive decline with TBI and age. So there is a bit of technical jargon in this video, but the point of it that hopefully you guys can understand is that hormones are critical to neurocognitive health, and that we can and should replace them because we now have the evidence, solid, real evidence, backing up what we've been doing in hormone replacement therapy way before I got into this. This whole field started perhaps 40 years ago, but we're riding here on the shoulders of people like Dr. Mark Gordon and others who have been the pioneers of this. But now we have the research, so please share this video so that people out there understand that bioidentical hormone replacement is and should be the new standard of care. Enjoy.
This 2019 article addresses what has been unfolding for decades, that neuroinflammation can exacerbate or initiate neuropsychiatric disorders. It's about time that we start seeing articles that are clearly putting the two halves of the puzzle together to help support people like myself that 18 years ago started approaching things from this avenue. So we'll state a little bit about neurosteroids, which are a class of steroid hormones that are produced de novo in the brain and have important functions in regulating neuronal activity. This neurosteroids were basically brought to the forefront by a doc by the name of Bellew in Paris, not Texas, Paris, France, which began in the early 80s. He found that neurosteroids are produced in the brain by glial cells from the substrate cholesterol. That's why you're now starting to see these incredible studies saying that low cholesterol is not good. And that's because it helps with all these neurosteroids in the brain. They're 35 plus. They're not just below the neck. So the diversity of function of these neurosteroids is broad as well as specific. They are tasked with jobs of keeping our neurological functioning at its best through protection, modulation of function, and repair. And looking at the brain, the frontal lobe, which is the most traumatized, if you look at statistics on which lobe of the brain is most commonly in traumatic brain injury involved, it's the frontal. The same thing with blast trauma in our veterans, the frontal lobe. And look what, the highest concentration of P450 is in there. And P450 is the inducing enzyme that takes cholesterol and starts the process in the inner membrane of the mitochondria to produce pregnenolone, which is called the mother of all hormones. So neuroendocrine disruption also leads to loss of neuroactive steroids. Those steroid hormones produced in the glands below the neck that gain entrance into the brain by way of the blood-brain barrier. The majority of them have to be actively transported, except free testosterone. Free testosterone through a gradient goes into the brain. That's why it's this thing of total testosterone is bull. Total testosterone should be scratched off the list, and it's only free testosterone because that's the one that gets into the cells to do the work. Total testosterone is what? Epitestosterone, DHT, estradiol, bound forms of testosterone. Anyway. Okay, so this was 10 years ago. The mechanism by which neuroinflammation interferes with hypothalamic control over the pituitary gland's production of FSH and LH was reported. They found that neuroinflammation alters the production of astrocytes prostaglandin E2. And it turns out that this PGE2 is required by the hypothalamus as a cofactor to release gonadotropic releasing hormone. Now, the gonadotropic releasing hormone goes to the anterior pituitary and has it generate and release luteinizing hormone to produce, in the thecal cells of a woman, their testosterone and then estradiol, in the Leydig cells of a male's testes to produce testosterone. And neuroinflammation shuts down this glial production. Right now, what we're dealing with in our practice is all the guys and gals that are coming to us post-vax with this scenario, not from trauma, because they found that the spike protein accumulates in the brain and leads to inflammation in the brain. Some people develop the post-vax or long COVID, and it's due to that issue. So sterility and hormonal deficiency. With the hormonal deficiency, you'll see depression. With sterility, you'll see depression. Everybody wants to be a parent, or most everybody. So cytokines belong to the tumor necrosis factor alpha family, which is an inducible transcription factor, and it activated by stimulation of TNF, tumor necrosis factor alpha. Specifically, TNF alpha releases NF-kappa B from its inhibitor protein, which they call I-kappa beta, allowing it to translocate into the nucleus where it triggers additional pro-inflammatory cytokines. Once NF-kappa B translocates into the nucleus, it can regulate over 400 genes associated with immunity, growth, and inflammation. And a side about the adhesion molecule beta-2 integrin that's highlighted here, this is responsible for the accumulation of leukocytes in the lungs, which causes COVID's, cytokine storm that happened in COVID. An article that was published during this peak of COVID was delayed by a year and a half because it told how to reverse this by the use of the neuroactive steroid DHEA, which significantly reduces leukocyte adherence to pulmonary mucosa, lessening the intensity of the storm. In the brain, sulfated DHEA, which is the active form in the brain, is a neurosteroid that drops the production of interleukin-6, thereby reducing the intensity of the cytokine storm in the brain. So getting your patients up there on DHEAS is very important to reverse this process. Another great article, just loved it because, playing the blues. Another great article, which is Cytokine Sings the Blues, is a good read since it presents an in-depth understanding of how inflammation begets depression as well as other neuropsychiatric conditions. And if you click this, I'll make arrangements for Bill to get a copy of this. And if you click this, it takes you to the full article, not an abstract, not one of those limited teasers. This is the full article, okay? So the theme here is very straightforward in that for all forms of inflammation create a damaging environment that the brain floats in. It is this abnormal environment that alters brain's ability to glean benefits from medication. So that's the reason why we have a lot of failures of medications. Failure of neural feedback, failure of hyperbaric oxygen, failure of light therapy, and also treatment with psychedelics. I just published a new article on how neuroinflammation disrupts or impedes the ability of psychedelic-assisted therapies from maximal benefits. It's at the website. So studies have shown that cytokines produced below the neck, like secondary to gut issues, autoimmune diseases, Crohn's disease, rheumatoid arthritis, psoriatic arthritis, and so forth, can create what's called the sickness behavior with hypersomnia, fatigue, lower libido, irritability, and sometimes fever. We have seen this syndrome frequently in long COVID and autoimmune diseases. What's neat is medications like Enbrel, which block interleukin-6, and then they have another one that blocks tumor necrosis factor alpha. And when you use it, there autoimmune disease subsides and you see this reprieve from the neuropsychiatric condition because you've dropped the inflammatory cytokines. And in our population, my daughter does it because of her focus on gut brain and gut health. She'll run people through something called a GI map, phenomenal test. And she'll find the things that are causing inflammation of the gut, whether or not it's dysbiosis, leaky gut, malabsorption, whatever. And there are markers unique for inflammation in the gut. And that might have been the reason why, in my treating them, they did not get 100% better. But once they get their gut addressed, they come up to closer to 100% improvement. Okay. Individuals who develop symptoms like sickness behavior without a history of TBI should have their gut looked at. And this is basically what I already said. Okay. So both physical and biochemical changes induced by traumatic brain injury can disrupt the sympathetic nervous system, leading to excessive release of catecholamines, epinephrine, norepinephrine, and all the things that increase fight and flight and create the dysautonomia syndrome. Syndrome. I think I posted on my website. It's a 2-minute video of specifically this condition with heart rate variability getting off, and fix the inflammation, it gets better. We've got guys who have hypertension on 3 medications that are barely working. They get their inflammation taken care of. They're off their blood pressure medication. And here's a 2017 article from the UK. And what they did was they looked at psychiatric disorders and they looked at the elevated cytokines. And what seems to be consistent is the interleukin-6 and tumor necrosis factor in schizophrenia, depression, bipolar, anxiety, OCD, and what they call PTSD. So a comment about this toll-like receptor 4 that I commented about earlier, where gram-negative pathogens like E. coli trigger it. And peroxidation, lipid peroxidation will trigger it. Very few things trigger it. And it turns out that if you use narcotics, opioids, that it has a crosstalk between the mu receptor for modulation of perception of pain. It doesn't do really anything pain except make you think that it has. And it crosstalks with toll-like receptor 4, which triggers NF-kappa B to translocate into the nucleus to induce transcription of pro-inflammatory cytokines, and you end up with more pain. The way that we've addressed the pain scenario is to fix the inflammation. And that's how we've been able to, neuropathic pain. I'm giving a presentation to Georgetown on neuropathic pain, which is this scenario with the peroxynitrite. You adjust them, you lower the opioids, and you can do away with pain. You can improve the pain scenario. So all metabolic pathways are dependent upon the presence of adequate amount of mitochondria-derived ATP, the energy molecule for all cellular functions. It is with ATP that NF-kappa B can translocate into the nucleus with a potential of turning on 400 different genes. The same ATP can also be used to drive repair mechanisms, transmembrane ion transports, and protein synthesis. NF-kappa B has a direct and indirect effect on the functioning of mitochondria and therefore an effect on their ability to produce ATP. So when NF-kappa B enters into a mitochondria, it damages cytochrome C required for oxidative phosphorylation, and it also causes the mitochondria pores to open up. And when these pores on the mitochondria open up, the cytochrome C exits and initiates apoptosis. Regulate inflammation, you improve that. So mitochondrial dysfunction, there are some of the things that it does: damage MDA, activate cap spaces. Cap spaces, like cap space 3, they're called the messengers of death. The minute they're turned on, the cell's dead. It will force them into the process of apoptosis. Okay, fortunately, when the level of oxidative stress reaches an apex, certain redox signaling molecules like nitric oxide will induce transcriptional programs for mitochondrial biogenesis. So even though you've got these damaging effects of peroxynitrite and heavy oxidation, it will trigger for a secondary system, which is nitric oxide, which will save the day. Well, not save the day, but it'll improve the outcome. So under this program, mitochondria are generated to help in the repair process for improved ATP production. In looking at prevalence of TBI in terms of acute and chronic and its influence on hormone production, you see acutely in 3 months, you've got 56% hormone deficiency, and these are the percentage of each that is deficient. And then there's an improvement, and by 12 months, you've got a 20% improvement, and these people go on to develop chronic. And this is the population of people that I see mostly is 1 year, usually 1 year and more after their trauma. And they've been through, lots of docs, and they still haven't seen the light of day. And we run tests that have not been run before. We find the problems, replenish it, replace it, they get better. And we also address the inflammation at the same time. Now, here are hormones that influence neuroinflammation. What I mean is by dropping the negative ones and increasing the positive ones. Growth hormone drops C-reactive protein, drops tumor necrosis factor alpha, and increases the most potent anti-inflammatory interleukin 10. And you can see IGF-1, testosterone, all these have benefits on all the pathways, or many of the pathways that create the triggering of traumatic brain injury, inflammation, neuroinflammation. And you see pregnenolone and allopregnanolone. Allopregnanolone comes from pregnenolone through progesterone, and pregnenolone is $80 a year, and it becomes allopregnanolone. Pharmaceutical product called Zurosa came out 6 years ago for a slim $34,000 a year just for the medication, and then about $80,000 more for once a month being in the hospital for 30 hours getting a slow IV infusion. So you just use progesterone or pregnenolone to get the benefit. Okay, we're almost at the end. We already talked about testosterone and improvement. It also directly drops all these pro-inflammatories. Let's see. Yeah, drops all those as well. So, summation. Any form of trauma will increase the production of free radicals, thereby elevating the level of oxidative stress. The rising oxidative load activates microglia. It's probably the number one activator of microglia are the pro-inflammatory oxidative free radicals, and induces the production of pro-inflammatory cytokines. In an acute process, inflammation does its thing, and then it gets turned off by the presence of these anti-inflammatory cytokines, indicating resolution of the threat. But as I said, it's not always that way. Many of the traumas that are perceived as being acute in nature can be insidious and indolent, like the stealth syndrome that they talk about, until symptoms relative to cognitive, mood, and libido become problematic. And this represents the chronic phase of the condition. Within the conventional approach, a neuroendocrine assessment is rarely performed, and when it is very limited. And to some degree, they don't interpret it to the degree that our software does. This is why the mainstay of treatment is based upon medication that masks the symptoms, because they haven't figured out how to treat the cause. So based upon the results of a 28-point biomarker panel, we do a customized treatment protocol is designed that replenishes the neurosteroids that are objectively found to be deficient, along with the neuroactive steroids that are below the neck, while addressing neuroinflammation. Key to hormonal replacement is that they are replenished to the therapeutic level, not just within the box. They have to be to the therapeutic level, which is the second to third quartile of the range. So it doesn't matter what my range is, you just look at the quartiles of your laboratory's ranges. So inflammation and mitochondrial functioning are concurrently addressed with nutraceuticals like CoQ10, PQQ, and so forth. So, without electricity, the lights go dim and then they go off. And this is our 2019 to 2021, 840 clinical cases. And we do what's called the monthly program report, where they fill out 25 points of subjective assessment of psychological, physiological, and physical functioning. And this is the percent that were 10% better in that time frame, 19 people, and how many people were 50% better, 60, 70. So it turned out that 78.3% of the participants were 50 to 100% better within an average of 12 months on protocol. So that's it. So if there are any questions, you'll get this and see that there's a software package. It took me 9 years to write a software package. I was in computer electronics before my father died of bone cancer. That threw me into medicine. So this is a computer software that analyzes your labs, not just TBI. It does TBI, wellness, anti-aging, age management, does all of it, and interprets it and gives you a 12-page report telling you not only what it diagnoses or finds, but also what it recommends to treat the patient. And then, we have a new online course, 7 lectures, over 16 hours of training with 600 articles with red arrows, and you can download them. You can put them into your collection. So that's it. I'm going to stop sharing. And let's see, I don't have my scotch here. Hi, Hyla. How are y'all? Hi, Meisel.
You're doing great. You're doing great.
Hi,
Great as always, Mark.
Well, the bottom line is my passion here is because I'm hoping that someone will pick up this passion and take it to the next step and state, doing like you've done. You've honored me by taking this information and disseminating it within your peers and your group of colleagues here. And that is the reason why, I spend many days doing it. And, you called me, said, can I do it? I'm here. I've got another one tomorrow with the military.
Yeah,
okay.
It's it actually takes, what we've learned from what I call hormone-centric looking at patient care to the next level. It really gives you a and these people the thing is, these people get better. A lot of, if anyone's dealt with the head injury people, they absolutely get better. We actually change lives. And seriously, how many at least on the medical side can say that. I'm not talking about surgeons, but on the medical side, I know I was many times sitting and saying, "What am I doing? What am I doing with myself?" Then these folks show up, and in 3 months, 6 months, 9 months, they go from basket cases, living under a bridge, estranged from their families, totally useless to, they get their lives back. So that's what did it for me. Joel down here at the bottom, he was my first TBI patient. This is what he started it all. And you see that beard that he has there. He lets me talk about him. He had no hair. He had none. He had no body hair, no head hair, nothing.
Zero testosterone. What? Zero DHT.
He wandered in one day, and for whatever reason, we hit it off, and he started telling me, his story, and I started asking, the hormone questions. And that sounds like testosterone. That sounds like thyroid. That sounds right. He was on, with Joe, you can tell your story. He was on 13 medications, 34 pills a day.
I got down to, I was about 143, 144 pounds. Mom moved in to feed me by hand just to keep me alive. VA said it was in my head, Dr. Gordon, and that I was stressing, and I need to quit stressing, and I need to eat more. And I had to break away to Whole Foods and start learning about that whole situation. And then I learned about Judy Mikovits, and I learned about some of the corruption with Big Pharma. And then by the grace of God, we had a magazine with all those woo-woo doctors in the back. And that's where I found Dr. Clearfield. And I went to him, and there was another veteran that was already there that was diagnosed with cancer that didn't have cancer from the VA. And he told me to stick with Dr. Clearfield. And it was just mind blowing. The anxiety was so bad that neurologically I couldn't breathe on rhythm. I had to count animals to breathe. It was just disgusting. It was bad. Okay. And then once he got into your book and he started to really, go into this, it was life changing for both of us, point blank.
Yep.
Now I remember so I said we gave him we wrote up a lab slip and he took it to the VA and they laughed at us. So
yeah, Joel, you know what I get?
Happened to me.
A lot of our vets will take their report that we give them plus a copy of the labs to the VA doctor, and the VA doctor looks at it and says, I don't know how to read this. So then he gives them the interpretive report, our MOA software report, and he looks at it and says, wow, but they're not going to do it. They're not going to do anything. That's why it's taken me 14 years to get April of this year. I got invited to Walter Reed to lecture to the functional medicine people. And the head of the department, Dr. Spivak, liked the presentation. He didn't tell me. It was my liaison that did. And I ended up writing a 10-page report. And this is the presentation I gave them. He loved it. And I took it and wrote a 10-page article on it. It's on my website under the name neuroinflammation, the same name, I believe, neuroinflammation, the road to neuropsychiatric illnesses. And next day he calls me up and he says, we got to work together. So we have a project in Washington in February, talk about neuropathic pain and a little bit about what we do. So I'm bringing my partner, Andrew Marr. Some of you know Andrew Marr, it's Green Beret, who in his 4th tour of duty was blown up and ended up 6 months later on 13 medications, full-blown alcoholic. And that's the movie Explosions. If you haven't seen it on Amazon Prime, it's $3. Okay. And it talks about not only him, but there are 10 cases. I have a very small part to play there because it's not about me. It's about hope for the people like you, Joel, and others that have experienced the effect of traumatic brain injury, which brings me, can I answer some of these questions so I can go and have dinner?
Yeah.
Okay.
The first question is, what is the mechanism of Cymbalta and lipid changes? Well,
That's your question. I don't touch those.
I had to look that up myself. I'm not an expert on this. All I did was look it up and found out that Cymbalta raises cholesterol levels. That's all I know about it. So,
okay.
If anybody out there knows the answer, let me know. If not, I'll report next time. So,
I can see the questions here. Do you want me to just go down them? Okay, the question about Sheehan syndrome and autoimmune TBI, is it considered an autoimmune TBI? Well, if you look at the core, Dr. Sheehan very clearly showed that there was damage to the stalk, the vasculature to the stalk, the pituitary stalk that leads to loss of blood flow to the anterior pituitary, and that's how you lose some of the cells there, the somatotropes, gonadotropes, and so forth. The ones that occupy the front half of the pituitary are the growth hormone ones. So those are the ones that get nailed first. So in the order, if you look at the literature, growth hormone's number 1, testosterone number 2 with the gonadotropes, number 3 is thyrotropin, and number 4 is corticotropin. So ACTH is affected. So it goes through that pattern. So Sheehan syndrome is primarily a vascular compromise with a secondary issue of breakdown of the blood-brain barrier, because the astrocytes, the inflammation that's set up by the ischemia that occurs to the tissue of the brain contiguous with the pituitary stalk, releases blood. Now, in blood is hemoglobin. In hemoglobin is iron. Iron causes what's called the Fenton reaction, which is an incredible inflammatory trigger. So that's how you end up getting the inflammation that leads to the damage to the astrocytes, which leads to breakdown in the blood-brain barrier. blood-brain barrier. So that's how the peripheral blood gets into the brain and initiates an autoimmune response. Because, as you know, say again. So the brain and the prostate are sequestered tissue, meaning they have a very protective mechanism, and that's why, you know, when there's breakdown in the prostate protective outer wall, you get things like prostatism, you know, non-specific inflammation. It's an autoimmune process. In the brain, we're now seeing with all these head traumas, occurrence of autoimmune. Okay, next, what about PTSD symptoms in non-TBI patients? Well, we have this fractalkine issue where under stress, no trauma, just stress, what happens is fractalkine drops due to elevation in cortisol, and the microglia, or the glial cells, the astrocytes and the microglia, are turned on and start dumping inflammation. And it's that inflammation that leads to setting fire to the brain. Just like being hit on the head, blast wave, certain medication, exposure to ionizing radiation, these all induce the same mechanism. Different pathway, you know, they say all roads lead to Rome. So different pathways, but they all create the same scenario. If you go to my website in March, I did a paper on off our veteran population where we looked at 79 veterans that had randomly come into the study, and we looked at them who had, by the VA, a diagnosis of just TBI, and who had a diagnosis of PTSD. So we have two groups. And what I did with the PTSD group is I looked for how many of them who had a TBI someplace before their enlistment, playing football and MMA were the two most common. And all of them, 100% of that group, had a TBI. So I had already treated them, put them onto a treatment protocol, regardless of TBI or PTSD. And the results were, in 1 year, 77% improvement in, and I'll clarify that in a second, 77% improvement in those with PTSD, and a 77.4% in those who had TBI. Now, what improvement is for us is 50% to 100% improvement. If our patients do not achieve 50%, at least 50% or more, we haven't really fixed them. And what we found, and a lot of my time is looking at why that group did not do well, why that group did not at least ascend above 50. And it turns out alcohol, lifestyle, poor nutrition, poor hydration, no exercise, no relaxation, no meditation, drugs, alcohol, I said medication. Gabapentin, horrible, absolutely horrible stuff, because it screws up the entire pregnenolone, progesterone, allopregnanolone, and pregnenolodiol pathways. And you need all those for the brain. So that's TBI. Cutoffs for cholesterol, that's a loaded question. In order for cholesterol to move forward to make hormones, you need to have luteinizing hormone. So the real issue is not how much cholesterol, but how good the level of luteinizing hormone is, because it's the rate-limiting hormone for cholesterol to be converted to pregnenolone. So you need to, look at luteinizing hormone. There are studies that talk about less than 160 being associated with cognitive impairment. My mother died from statin dementia, and she was put on horrific levels of statins. And the real issue was her hypothyroidism. The asshole up in Beverly Hills did not even look at her thyroid. I looked at it and found that it was low and started her on, appropriate T3 protocol or combination therapy, and started kicking her off all the statins and stuff she was on. I didn't get involved with her medical care, which was my error. Anyway, let's see, low class copy. Yes, I will make a copy of this presentation, and you'll have access to the clicking code, the down arrow. I'll make it available to anyone who donates to the Warrior Angel Foundation.
Okay, we usually put the video on our website. Is that okay, or you want me to hold off on
Video? What video?
We're videoing you've been on video since we started.
Oh, okay.
I mean,
As long as you give my good profile, do with it as you will. Okay, and I was just kidding about the donation, but I'm self-funded. Everything I do goes into our veterans account. My partner Andrew has a 501(c)(3) Warrior Angel Foundation. So every year I transfer funds from what we've generated in our practice to him. I leave a little bit to buy one bottle of scotch, and he gets funded, as a 501(c) or C3 or whatever it is. Can I get a copy? Yes, you can. And that's, Dr. Spector. I'm very enthusiastic. I see 3 psychiatrists here.
That's
which is
good.
great. Which is great.
We're making progress.
We've got, I think, in total about 29 or 30. We just got one in Florida and one in Georgia. Okay. Let's see. Have you used or heard of MERT, magnetic E? Yes, I have. I just gave a lecture to the International Society for Biofeedback. Is it, neurofeedback and research. Yes, I do not use any of these modalities. I refer them out to other people after we've fixed their neuroinflammation, because what we find is that if they have neuroinflammation, you won't be able to maintain the beneficial effects from all these protocols. Not unless you fix the brain and get the chemistry. In the movie Quiet Explosion, there's a surfer by the name of Sean Dollar, who had 80 sessions. He talks about it. He had 80 sessions of HBOT. And 2 weeks after stopping, he was feeling great. 2 weeks after stopping it, he crashed and burned. His doctor, Scott Shear, and Dr. Daniel Amons, they ended up referring him to, and we did our laboratory testing and found deficiencies. And once we got him onto replacement, 2 weeks later, he's doing great, except he was told, don't go back surfing. What did he do? He went back surfing, he crashed and burned. Why? He was adrenal insufficient. And the adrenal insufficiency was from all the time that he had been stressing from his trauma. Let's see, low dose naltrexone, low dose 4.5, or is it 2.5 or 1.5? I don't know what low dose is these days. But the article that's there about narcotics inducing the toll-like 4 receptor are real. So every time you use something like naltrexone or a low dose narcotic opioid, you're actually increasing their brain's inflammation. So you've got to find a balance. Yeah, they might feel good, they might feel better, but you're persisting. And the way you can check it, which I don't really like, is with IL-6 and a TNF-alpha test. Oxytocin help with TBI. If you're deficient in oxytocin, yeah, that'll help. If you're looking generically at peptides, you've got the ARA290, you've got the CMAX, you've got the NAC CMAX, you got the CMAX acronyl, which are peptides that work. They're very good. I like the thymosin 500 or 4 beta. I like that because it helps cells repair, but you have to use it in conjunction with either our protocol or with other peptides.
You ever use cerebrolysum?
Say again?
Cerebrolysum. You ever use
Cerebrolysum? Yeah, I know about it. I was like, where it was coming from out of Russia, cerebrolysum, I was a little bit concerned, even though they said they did test it for prions and all that, because it comes from animal byproducts. I think we have safer peptides. Okay, go look at the origin. The other thing is, what labs do you run to assess the level of inflammation? Great question, and that is Zoom User. Okay, thank you, Zoom User. I don't do any inflammatory cytokine testing, and the reason is straightforward. Where are interleukin 1, 6, tumor necrosis factor alpha, where are they produced? Throughout the entire body. So how can you tell me that I'm doing a blood test and that's from the brain and that's giving me selectively just about the brain? That's not the case. We did a 6-month study on our veterans. The cytokine testing is not cheap. And what we did find is that if their cytokine interleukin 6 and tumor necrosis factor alpha were elevated and we lowered it through our treatment, they got better. But I can't tell you categorically that this is from the brain. As I said earlier, cytokines coming from the gut or cytokines coming from an orthopedic joint can generate and go right into the brain and induce the inflammation. So I don't do any inflammatory markers. Yeah, you can do your C-reactive protein, your homocysteine to make sure you're not adding to the inflammation. But the real issue is I don't do that. And what I do is from that article that came out of 2013 talking about neuroinflammation shutting down gonadotropic releasing hormone, and you'll have low luteinizing hormone and low follicle stimulating hormone. That's what I run on. I run on that pattern there. And then also there's the Jostel index, which is commonly called the TSH index. It's a mathematical model that looks at the relationship between TSH and T4. And if the mathematical model calculation comes out 1.3 or less, the problem is with dysregulation of thyroid axis is coming from the trauma to the brain. And if the TSH index or the Jostel index is greater than 4.1, the problem's coming from the thyroid gland. So you can pick up indications of Hashimoto's and Graves' disease. Another thing that the software, it's an AI software tool, has done is showed us that if you have low vitamin D and elevated reverse T3, that you have a 70% concordance of picking up Hashimoto's. So our software does that analysis for you. So you just run it, it'll tell you, we suggest running a TPO or the Graves antibody, the thyroglobulin antibodies. Let's see. Routinely find pregnenolone near zero in patients. Well, partially it depends upon the technology that you use. Most healthcare providers trust in the laboratory, but they don't know what it is that the lab's doing. There are 3 standard techniques. The best one is the liquid chromatography, LC-MS. It's a 3-tiered analytical system that is the gold standard now. Pregnenolone is added to it just of late. And there's chemoluminescence and ELISA tests, and the worst one is RIA. So if you look at the laboratory technology that your lab's using, the low-rung ones like LabCorp and Quest, you look at what labs they're doing or technology they're doing, and that'll give you an understanding of why might these levels be low, okay? So if pregnenolone is low, the benefit of pregnenolone, it becomes progesterone and then allopregnanolone. You need to read about these 3. The pregnenolone and progesterone and allopregnanolone have 2 halves of a puzzle. One half is it generates the GABA in the brain, is one of the things that pregnenolone does. Another thing pregnenolone does is it upregulates acetylcholine in the brain. So you have patients with Alzheimer's and they give them what? they give them acetylcholinesterase inhibitors to stop the destruction of acetylcholine. And the reason why it really doesn't work is because there's no acetylcholine being made for it to work on, because inflammation through the peroxynitrite shuts that off. So pregnenolone, anti-inflammatory on one side. On the other side, it's a free radical scavenger. It's synaptogenic, which means it improves the neuron's ability to communicate through synapses. It's neuroregenerative as well. So the product called Zerusa came out for postpartum depression, anxiety, and they haven't started talking about sleep benefits, but incredible sleep. If you have low level of pregnenolone, your patients won't sleep. They'll, I had a Marine come into the office, and I had his labs in front of me, and I said, "So how's your sleep?" He says, "How many hours?" I say, "How many hours are you in bed?" He says, 13 hours. I said, "Damn, you must wake up feeling great." He says, "On the contrary, I wake up feeling like I never put my head to the pillow." I'm looking at his pregnenolone level. He doesn't have any. 2 weeks later, giving him 100 milligrams 15 to 30 minutes after dinner, he's sleeping like a baby. Also, migraines started to improve. Inflammation is migraines. Okay, let's see. 40/50 PTS with Sheehan's should be treated system. With Sheehan's, stroke, subdural hematoma, any process that allows for blood material to get into the brain tissue, you need to address the inflammation. You need to douse it. You need to put it out. And since Bill William gave me leeway, which I usually don't take, is we spent 16 years developing a product called Brain Rescue 3. We also have Brain Rescue 1, Brain Care 2. We have a product called Clear Mind and Energy, which we launched with the Navy SEALs and DAM in Virginia Beach in 2017. Then our second product, which is purely the Clear Mind and Energy, cleans out the cobwebs. No caffeine, cleans out the cobwebs by how it regulates nerve-to-nerve interaction. We launched that with the SEALs in March 2017. In May of 2019, we launched our Brain Care 2, which is purely our anti-inflammatory product. And I list on my website, you can see everything that's in it. I don't hide anything. What makes our products work is a patented delivery technology that came out of Israel. And that allows our stuff to be absorbed without being destroyed by gut acid, and gets rapidly absorbed because of the nano liposomal particle. So the Brain Care 2 we did on a study with the medics out of Fort Campbell, Kentucky, 90-day program, 70% improvement in their symptoms. They connected me with their congressman in the state that they worked with, a Dr. Mark Green in Kentucky. And then the last one was 2020 with the Brain Rescue 3. I lectured to them on one day. The next day, they send me a group of active Marines who are getting ready to be discharged, medically discharged. And you know how long that process can take. 6 months, 3 months, a year, whatever. And we put them onto a protocol of one product, no blood work, nothing. It's the Brain Rescue 3. They took it pre-breakfast every morning for 90 days. But every 30 days, they filled out an 18-point questionnaire that had psychological, physical, and physiological questions on it. Migraines, pain, joint pain, body pain, depression, anxiety, sleep, quality of sleep, and so forth. 65% of them were 50 to 100% better. 35% of them were less than 50%, 50% or less. And those are the ones that we ended up spending more time to figure out why. And it was medication related mostly. PBM is TBI. What is, Richard, you still there? What is PBM? Is he allowed to talk?
He's allowed to talk.
Okay.
I don't know.
Hey,
Yeah,
how are you, Richard?
nice to see you. It's
PBM?
PBM is photobiomodulation.
Okay, got it. You can go back into microphone off. Great question. The one of the veteran foundations called Gray Team out of Orlando, Florida. They support PBM, and the way PBM works is the 940 angstroms of light penetrates the brain and shuts off, denatures the pro-inflammatory cytokines. So transcranially, you can actually influence the amount of inflammatory cytokines that are in the brain. So it's the guy who founded it is Kerry Riebach. His father was 93 when he came to us with dementia, and 60 days later, his dementia's gone. Now we're at 6 months, and he's on television now, and his word skills, his cognition, his reaction, his response to the interviewer, phenomenal. So I don't know if you've gotten the video. I sent it out a couple of times. It's 1 minute 47 seconds. It's Edward Riebach. He was Army from Korean War. He just turned 94 last week.
Do they have to continue the PBM indefinitely to retain the?
No, because they're on our. I donate to them, to Gray Team, our two products, which is Brain Rescue 3. They take it in the morning, and Brain Care 2 they take before dinner, and then they give them their photo modulation, and they're doing really well. And he's keeping track of those that he puts onto our nutraceutical protocol and those that aren't, to see how they respond. So they freely fund the photomodulation.
Are you familiar with Dr. Naser's work out of Boston, VA?
Say again?
Dr. Margaret Naser's work out of Boston, VA?
No, I don't follow that. What happens, Richard, is, they'll tell me what they're doing. I'll look up at the modality, and what I look for are mechanisms. So I find the mechanism and how it works, and I'm supportive or not. And
she is the one who has led the movement for photobiomodulation.
Yeah, and that's why people like Kerry needs to communicate with her. I'm just, everything's falling off my plate right now. Okay. Can I repeat the Jostel index? Look it up. Okay. And I say that with kindness because it's an equation that you can learn and you can apply to your T4 and T3. And if it's less than 1.3, central problem. If it's greater than 4.1, it's a peripheral problem. So if you go on and look up the TSH index, it was developed by Dr. Jostel out of Chicago, and there are maybe 10, 15 good articles, and almost every single one of them has the calculation. If you go and say on Google, you say TSH index calculation, comes right up. So you can get the calculation. It's 0.1354 times 4.5 times the T4 plus TSH, and that'll give it to you.
Yeah, those of you who've heard me speak on this, especially the laboratory, you've heard this before. I called it the TSH index. I didn't know it had a name. I didn't know it had Jostel index.
Yeah, so. It's Dr. Jostel. Okay. So what I've written is a paper, a one-pager for any of our veterans who are being denied disability, and I find that they have the TSH index indicating they've had brain trauma, head trauma. I'll send them the document and tell them, go read. Here's the science that supports it. Let's see. Can you put your website with the products? Let's see. Isn't there a thing here that allows me to? Yeah.
Yeah, you type in the chat.
I see it. I see it. Okay. So www.tbihelpnow.org is the website with all the education. It's an educational site. To access the products, it's at www.millennium Health, Millennium Health Store.com. And if you go to the website and you check off a little box that says something, I agree to receive promotions and so forth, we send out maybe one educational a month. And with the educational, we have a code, and that code will give you a discount. The discount only works if you are a subscriber or check that little box. And the discount code, or the checkout code, is MH. Oh, I know which one that is. It's phase 2022. There it is. The phase 2 protocol. We've got about 8,850 some odd people who are utilizing it through the website. And that's how I get funded, because I'm self-funding, to pay for 1,500 veterans to come into our program. We pay about 60%. Okay. Question, David?
There's a question on that you skipped over. What's your thought on Nudexta? I don't know what that is.
Nudexta, I'm sorry, is like a DEXTA scanner or something. I don't even know what it is, so we'll just pass on that.
Yeah.
I'll look it up to educate myself. In these forums, I get educated, and I take advantage of learning these things to see if they are.
Yeah, I don't know. I never heard of that either.
We'll
There was
find
another
out.
one you skipped. What if the TSH is very high, say around 20? Is there any indication from this, or is it still depends on the ratios as mentioned? So
If TSH is elevated, this is one of the not quagmire, but one of these processes to analyze it. What happens if TSH is elevated and you're now making great amount of T4 and converting enough amount of T4 to T3? Is there a problem with that? Let's say your TSH is 7. Most labs, it's what? 4.5 to 5 point something is the upper limit. Let's say 5. So what if it's 7? Are you going to jump on and give them thyroid?
but it's always the dilemma, because the endocrinologists don't. That's all they look at is the TSH, and they don't know what the free T3 is.
Correct. And they don't know what the T4 is. Well, my answer is no. That is compensatory hypothyroidism. The body is handling it. When should I step in? I should step in on 2 situations. One, if their prolactin is elevated, because elevation in TSH causes elevation in prolactin. Elevation in prolactin shuts down luteinizing hormone, and you can't make testosterone, whether it's thecal cells or Leydig cells. You can't make it. That's one. Number 2 is if their level of TSH is very high and they're not converting compensatory, they're not making enough T3. And if I'm seeing that their T4 is more rapidly converting to reverse T3, then I'll start looking at selenium. Selenium is a rate limiting for T4 to T3 that's functional, and selenium deficiency will cause T4 to go to reverse T3, as well as iron deficiency, ferritin deficiency, B12, B6, and deficiency and elevation of cortisol will cause the preferential production of a reverse T3. So, and the best way to treat reverse T3, if they're symptomatic with low T3 syndrome, because their T3-RT3 ratio is less than 1, and then you'll give them a little bit of pure T3, a quarter tablet of a 25, or have a compounded T3, and you use it for a couple of weeks. What does that do? Like homeopathy, shuts down the conversion of T4 to reverse T3. Then you stop it during the time that you're giving them their selenium and making sure their B12, B6, folic acid, and ferritin and iron are appropriate.
FYI, the selenium will also raise your testosterone levels by can be up to 30%.
How does it do
200
that?
micrograms within 8 weeks.
How
and
does it do it?
And it will also lower the thyroid antibodies. So
Yeah. And how does it do that?
I'm gonna have to remember that.
I'll make it easy. It inhibits the 5-alpha reductase.
Mhm. Okay.
So what you have to do is you have to keep track of, there are two pathways that 5-alpha reductase work. One of them is testosterone to DHT, and the other one is pregnenolone to allopregnanolone. And if you block that pathway too much, what will happen is you'll start getting symptoms of deficiency of allopregnanolone, which is depression, anxiety, insomnia, and mood swings, volatility, anger. And that's what prolonged testosterone treatment will do, because it consumes the 5-alpha.
Right. And then for our sports fans out there, and what drug also has the same effect? I know you know.
Of which?
Of the blocking, when you block the 5-alpha reductase, when you end up with
Okay.
Emotional and issues.
Yeah, absolutely. Body issues too.
Right. Those of you out there in cyberspace, you know what drug that is.
Mm-hmm. Okay.
So,
I think that's
we'll answer that quiz next week, so you'll have to come back.
Which drug is it? Trenbolone?
Huh?
Yeah, what about it? It's a DHT congener. Yeah, it's like nandrolone decoinate, it's like Anavar, it's like Winstrol, it's like Tribolone, it's like Mestirolone, all those things. Used properly and blended with testosterone, it's good, because the problem with all the DHT congeners, DHT-looking things, is they don't go into the brain. And what have we found? We found that when free testosterone gets into the brain, it converts to DHT. The other stuff doesn't get into the brain. So if you're only using nandrolone decoinate or any of those DHT congeners, what happens is you starve the brain of free testosterone, and you end up getting damage to the limbic system, the amygdala, and you get anxious, you get paranoid, you get, startle response, okay? You get an increased startle response. So if you're going to be using any of those DHT products, always make sure you're putting in some Sustanon, or you're putting in some testosterone propionate, or a blended propionate cypionate, and you won't get into problem. I mean, my partner, within an hour of getting his first shot of testosterone, was better, because we developed in 2002 a blended testosterone, 20% testosterone propionate, 80% weight per volume of testosterone cypionate. The cypionate takes 36 hours to separate from its ester. The propionate takes an hour to 2 hours. So you get it, boom, into the system, goes right into the brain. He talks about it in one of our Joe Rogan sessions. So it really works well.
Hey, Dr. Gordon, what about iodine? Stefan has done a beautiful class on this. Dr. Lewis is talking about it. Dr. Brownstein has a class. We know a Dr. Michael Nelson here in town. Mm-hmm. He has 12.5 milligram potassium iodide and iodine pill. Mm-hmm. And I think it has something to do with everything that's going on with all the EMFs and EMRs.
Yeah, I used to dispense the low dose iodide, in the past.
Okay.
Now I have it as part of one of our products. So yeah, but iodine, you just have to monitor it. I mean, you have to keep track of it. And if you're eating, is it true that they're taking iodine out of salt? There was some article that I saw that they're looking at taking iodine.
No idea. So
yeah. Anyway, well, you eat properly, you'll get exposure to it. Like sea salts, real sea salts. They've got, you look at, there's a product I'm looking at, it has what? 40, 50 minerals in it. That's one of our problems, is we're mineral deficient. We're drinking pounding water, distilled water, filtered water, has nothing in it.
Nothing. Yeah.
Nothing. We've got from another company, we've got a multi-mineral that works very well. I take multi-minerals, the drops, but
Right.
okay. But it has some iodide in it. Okay. All right. Anything else?
Do you have any experience with exosome injections via intranasal injection?
Oh, great topic. I'm just reviewing the literature on intranasal stem cells. But what's in stem cells? Exosomes. So if you got exosomes and you snort them, it should do basically the same thing. But there's a doc that after I read these papers, I'll interact with relative to nasal snorted. I can't see snorting cells though. They squirt it up.
They inject it with a syringe.
Yeah, I'm not there. In 2013, I was in Dusseldorf doing third ventricle injections of autologous stem cells that were augmented in Haifa, Israel, into brain, doing a project with a Dr. Haberling. You can look him up. And the patient had brainstem hemorrhage, all the classical brainstem hemorrhage. Within 3 days, they were disappearing. He was still wheelchair dependent, but his speech was better, his hearing was better, his mobility in his body was much better. He didn't need a retention. He didn't need to drink his coffee with a straw. It was quite impressive. And then the German Bundesrepublik shut down Dr. Haberling's center. He ended up in Turkey, in a hospital with Turkey, with a tank in front of the hospital. I wasn't going there. So, but stem cells, exosomes are great. Peptides are great. Exosomes have more in one punch than peptides do. And, take advantage of the peptides now because the FDA is slowly whittling down our availability.
Yeah.
How about RG3 ginseng?
As a abbreviation, I don't know that. And it was RG3 oxytocin or RG3. No, with TBI. If anything that you're talking about has influence over the inflammatory cascade in the brain, you'll get benefits. In our Brain Care 2, which is the main anti-inflammatory, is DHA, is quercetin, is gamma-tocopherol, is ascorbate palmitate, is what else is in there? B12, methylated B12's in there. One more that I'm missing, glutathione is in there. And each one of them has tens of thousands of articles talking about their benefit in the neurocircuitry. And I just read them and take it and make a product. And then we did, 16 years of clinical testing on the Brain Rescue 3, 8 on the Clear Mind and Energy. My oldest daughter, during residency, we came out with the prototype of Clear Mind and Energy. And she says that her residency, internal medicine residency in Pennsylvania, she was able to get through it without a sweat because she would pop the liquid, the goo. She called it the goo. It's Clear Mind and Energy. So you can read on the website, you get the Brain Rescue 3 data sheet. It has all the products, all their composition. And do with it, use it any which way. Mm-hmm. So let's see, 5 new messages. Oh.
Are you saying you must give pregnenolone when you give testosterone since it soaks up the 5-alpha reductase? Is that what you're saying?
No. If you give testosterone or estradiol, what key hormone is shut off? And that answer is luteinizing hormone. What's the function of luteinizing hormone? It's the rate-limiting hormone to convert cholesterol to testosterone, to pregnenolone, and then down the entire cascade. So if you give just testosterone and estradiol, you are shutting off 35 plus brain hormones. So what we do is we give pregnenolone and we give DHEA because they're at the top of the bifurcation. Pregnenolone becomes DHEA, pregnenolone becomes progesterone. Well, it becomes pregnenolone and progesterone. So whenever you're using testosterone or in a male and estradiol, testosterone in a female, you have to give pregnenolone and DHEA. Otherwise, run the risk of shutting down 35 hormones. And the classical symptoms are a guy will go to the doc 4 to 6 months down the road and say to the doc, I felt really good at the beginning of treatment. Now I don't feel as good. The doctor says, okay, increase your testosterone. They're already on super physiological dosing of testosterone because they don't understand what the average production of testosterone is per day for a male or female that is strapping, muscular, healthy, doing very well. And they up the testosterone. So a month to 2 months later, they're worse. And the doctor hasn't a clue as to what's going on because they didn't do their basic reading in negative feedback. It's all about negative feedback. Have to monitor that pathway, and everybody wants to skimp it. Everybody wants.
Mark, what about the guys and estrogen levels? That AMMG. That's a hot topic, and I have my hard time wrapping my head around some.
Can't get over it, Bill.
What's his name? Neil Rousier was a great leader in that issue. I don't mess with estradiol because if you looked at all the symptoms, all the systems that need estradiol, nitric oxide synthetase. In order to make nitric oxide, you need estradiol. In order for you to make growth hormone in the brain, you need estradiol. In the liver, you need IGF-1 and estradiol. Neuroplasticity is based on what hormone? Estradiol. The heart, the lining of the arteries, intima, estradiol. Bone, estradiol. So if you start messing with Arimidex or anastrozole, which I never use, you run the risk of shutting down 8 systems in the body. So what do? You adjust your testosterone level. You give them zinc, which blocks the conversion of testosterone to estradiol through blocking estradiol synthetase. You can use EGCG, use pomegranate, you use a whole bunch of natural things to block it. But I have guys that are 2 to 3 times the normal level of estradiol. And they look at the number. I said, yeah, your estradiol is high. So they said, isn't that going to cause a problem? I said, no, because what counters the estradiol is the free testosterone. So if your free testosterone level is good, I don't worry about the estradiol, but I ask them, what symptoms do you have? And a lot of them will say none. The symptoms I'm looking for is nipple sensitivity, which is one of the earlier signs. They put on a shirt and it touches their nipple and it's sensitive. That is a clinical finding symptom of estradiol being too. I don't see it. Because they're a proportion of testosterone to estradiol. But, and if they're so concerned about estradiol and they're using anastrozole, they should look at the literature on neuropsychiatric damage from anastrozole. And it's all coming out of the fact that it screws up the chemistry in the brain. I've got a portfolio, someplace down the road. I can send it to you and you can disseminate it out. So it's a link to Google Scholar. And it's one of my searches in Google Scholar looking for patterns. And this is the...
You can send it to me. We'll put it on our website and then we can...
Yeah, don't expect it until early next week or so.
I'm not in a hurry.
Okay, good. But I'll get you this. I'll get you this PowerPoint presentation. I'll try and get it to you tomorrow between my work that I have tomorrow. I'll get it to you. It's it took me a long time to put this presentation together.
Yes, we know.
The articles.
We appreciate it greatly.
No, that's not what I'm looking for. The point is, so the only thing I ask is that you take the effort and you read as many of the articles as you can, because your knowledge of what this neuroendocrinology will just go skyrocketing vertical. And that's what we need. We need more people who understand that neuroendocrinology is where we all should be at, not at endocrinology. Endocrinology, for those of you who have, who aren't healthcare providers that have gone to a traditional endocrinologist, it's crazy. It's absolutely crazy. Every day I hear from, my vets about, they were sent to an endocrinologist and I showed them what you put me on and they said it's going to kill you. So I say, okay, get them, Joel, get from them what will kill you and how and what the mechanism is. And they come back with air. It's like the other pet peeve is you've got our patients who are on age management, anti-aging, whatever you want to call it, treatment, and they need a surgery. So what does the doctor do? The doctor says, oh, you're on any supplement? Yeah, stop them all. And then you ask the doctor, why do you want me to stop my this or my that? Oh, it's going to cause complications. Can you give me one article that talks about it? Oh, no, I don't have any. It all generated from two cases where someone had a facelift and bled more. They were on supplements. And then there was something with it was a cosmetic surgery and an orthopedic surgery, but it had nothing to do with it. They're just trying to point the finger at someone else's fault. Oh, it's your vitamins that did it.
But then they turn around and say the vitamins don't do anything anyway, right?
Oh, yeah, they say that it's a waste of the pharmaceutical companies. But in what was it when Larry King was on? He had throughout the prior years before this date, he had docs coming on basically saying, from all the television shows, the docs representing the Channel 4, Channel 2, CBS, NBC, they were all saying vitamins are expensive urine. And then literature comes out showing that it isn't. And you see them coming back to a show basically saying, we were wrong, but you can use, Dr. Oz's formulation of vitamins, or else the doctor from 2 would get on there, or 4 or whatever, and promote themselves because it was bandwagon. They just joined it. But they,
Right.
you know what happened. Anyway,
Yeah.
I think
So-
we're done unless anybody has
One more.
What?
Stephen Hartman says he uses synapsin for TBI and an intranasal BPC and TB4.
Okay. Intranasal, wonderful. Straight to the brain. I use injectable. Our patients use injectable. And we have over 100 vets who were given disabilities, orthopedic disabilities. Those who have gone on to our tripeptide formulation of BPC 157, IGF-1LR3, and thymosin 4 beta, 2 weeks on, 2 weeks off, 2 weeks on, they're better. I just had one guy who had spinal fusion, L4, 5, and S1. And according to his doctor, in 4 days, he was 95% to normal. In 4 days.
Do you mix them all together in one syringe, or do you give them separate?
I mix them in one bottle.
Mm-hmm.
Yeah.
Is that a daily injection, or?
You use the formulation to deliver the specific micrograms of each.
Mm-hmm.
Is either given 0.1 cc's twice a day or 0.2 once a day. I had rotator cuff. My wife injected me with the formulation. In 3 days, full range of motion, pain. Some of you know that I was going into back surgery for L4-5 compression fracture with left side. And I woke up December 20th of last year, couldn't walk, couldn't put weight on it because of severe pain down the buttocks into the leg. What was it? L4, 5, S1, S2 root. And I went on to a prednisone pulse for 10 days. It helped, but it didn't cure it. And then I went on to the tripeptides for 8 weeks and was doing really well, but I still had problems. I added a 4th peptide, and in 7 to 10 days, I woke up on March 11th, had absolutely no discomfort, nothing. It was like before it ever started. And I was scheduled for surgery on the 15th in Colorado with Dr. Duhan, Dr. Brad Duhan in Denver.
Yeah.
And I called the anesthesiologist. Brad Willems? You know Brad Williams, anesthesiologist, pain management?
No, I don't.
Yeah, he's gone through our program, became buddies. And so I called him. He said he's got this neurosurgeon. So I called Brad and I said, look, I woke up. I have no problems. I'm walking, no pain, nothing, full range of motion, everything. He says, wait until tomorrow, call me. That was Sunday. I called him, still the same. Called him Monday, still. He says, now we got to cancel the surgery. I said, no, I want the surgery. It was discectomy, laminectomy. I said, because maybe this is just false sense of well-being and it's just going to come back. And the surgeon said, no, if you're having no pain, full range of motion, wait until it comes back. I said, but it's going to come back. It's been since March. And what I do is I work on my hillside, 45-degree slope, putting in trees, digging holes, pit shack, using a weed whacker, using all my garden tools, big time garden tools. No problem.
You can't leave us hanging like that.
What's the fourth hormone?
You're not going to believe me. That's why I don't tell people.
Yeah, we will.
It's a peptide for the skin. It's the GSK CU. And it turns out there are 2 articles that talk about it's addressing neural inflammation and improving blood flow to neurons.
Yeah.
And that's what I did. I added it. The fact that it's a nasty blue color, it's things going in, and it creates these little lumps that take 6 months to disappear. I've got one left. But I was using that on top of the tripeptide. And it could be coincidental. It could have been just the timing of the tripeptides. I don't know. Okay. Hopefully I don't have to go back to the drawing board.
I've always heard skin and brain are connected.
Well, the body's connected to the body. So I agree with you.
And
it's all one thing, right? We try to isolate it into heart and lungs. It's all working together, like all our hormones above the brain and below, above the neck and below the neck. All right. No more questions?
Thank you. Just one. If on testosterone, this is just to clarify, if you're on testosterone, you're also giving DHEA and pregnenolone?
Right. And that's because I run the tests.
Mm-hmm.
And what you'll find is people coming in to get their testosterone fixed, it's low. Where does testosterone come from? Pregnenolone and DHEA. So if you don't have enough pregnenolone DHEA, you're not converting it, except in cases where you have mercury and lead toxicity. Mercury and lead interrupt the 3-beta hydroxy enzyme that converts DHEA to testosterone. So what we found in our guys from Bragg, a lot of them had that pattern. The software brought it to our attention. And it turned out going into kill house, going into close quarter combat, you're breathing in mercuric chloride from the primer, and you're breathing in lead oxide and lead particulate matter from the round that went through the chamber, so you get a puff of lead and mercury. So you need to check that. Okay. All right.
Okay, everybody. Thank you so much, Mark, for everything. Everybody, we will be here again next week, same time, same station. And I had to come home because we had an internet problem at the office, and I don't have my schedule in front of me, so I don't remember who's going to be here next week, but there will be somebody.
Okay.
Maybe not as informative, but there will be somebody next week, same time, same station, 5 p.m. Pacific, 8 p.m. Eastern. And have a great Thanksgiving. And I hope, a whole bunch of us are going to be at the A4M. So, we should meet up somewhere. Since we, are you going to be there at all?
No, they don't want me there.
Oh, they didn't want me either. So I just go to the thing. I just go to hang out with Stefan and
it's because they thought they owned me. I set them up in 1999.
Yeah, they don't want me either. So we're
You're a traitor. They called me a traitor for lecturing for AMMG. All right.
So,
Take
okay.
care.
All right,
Bye-bye,
everybody. Thank you so
Thank
much.
you. Be
And
well.
we'll see you again next week, same time, same station. Thank you so much, Mark. It was great.
We'll do. Always a
Okay.
pleasure, Bill.
Thank you.
Bye-bye.